Obesity, now we know for a fact, it's a disease, just like diabetes, high blood pressure, and it's chronic disease and it's complex disease. So it's a disease that needs to be treated. The complexity of the disease calls for complexity of treatment. They have to have healthy diet, they have to have healthy exercise, they have to have behavioral modification, change how they live, and then they have to have surgery. Multidisciplinary programs like ours at MidState, we take care of every single factor. The first one is severely obese patients. By definition, we use what's called the body mass index. Body mass index is basically how many pounds per foot. And if the body mass index is above 40, and there are some medical problems related to obesity, that's an indication. With the new FDA rule, lab band can be used even for a body mass index of 35 without medical issues, or 30 with medical issues such as diabetes, sleep apnea, and uncontrolled hypertension. We do surgery to be healthy, not to lose weight. We do surgery to get rid of all the medical issues related to severe obesity or to prevent them. You are here to treat your diabetes, you are here to treat your sleep apnea, and you are here to be alive for your children. To be honest, people who emphasized on the appearance more than the health part of obesity don't do as well. We offer basically most of the surgeries which are offered anywhere else, from lab band procedure to laparoscopic gastric bypass, which is the gold standard. Now we just introduced gastric bypass done with assistance with the robot. We do the newer surgeries, which is sleeve gastrectomy, which is giving us a much better result. In the next few months, probably we'll be adding something called the gastric plication, where we don't cut anything, we just basically stitch the stomach together to make it as a small channel. Lab band restricts, meaning that it just basically makes two levels in the stomach. Instead of having one big stomach, we have a small one on the top and the lab band underneath that small one, and then the big stomach to follow. When we eat too much, our stomach stretches, and when it stretches, it tells our brain to slow down. With the lab band, these 2 ounces of chicken we eat will stretch that little stomach, and we feel not hungry anymore. We can inflate it or deflate it with a small device under the skin. You don't see, you just feel it. We can inject saline or fluid in it, and then we can basically dial up or down the speed of which the food goes from this small pouch. We can find that spot when we find that the patient does well. We exclude most of the stomach. We leave only small part of the stomach attached to the esophagus, which is the tube from the mouth to the stomach. And then we bypass, that's why it's called bypass. We don't want the food to go through the first small intestine, which is called the duodenum. That's the factory that absorbs the fat and sugars and stuff. So we want the food to go through the other intestine. So the patient in gastric bypass loses with malabsorption and loses with restriction. The reason we believe that gastric bypass is a gold standard, because it has been around for more than 30 years. So we know exactly the results, and we know exactly the complications, potential complications, and we know how to deal with them. When we do it, since somebody is type 2 diabetic, the majority of them go home without any pills anymore. Their diabetes is under great control from day one. So that's probably why we say that. Sleeve gastrectomy is a very simple concept. We just remove about 2/3 of the stomach and convert the stomach from a big ball like this. It's a high pressure tube, so the food does not go as fast as for a regular stomach. But most importantly, there is a ghrelin, which is a type of hormone which is secreted by the big stomach. And when we remove it, we don't have that hormone anymore. And we believe that this hormone is the one that pushes people to eat too much. We give them all the options in the first visit. and we see them 2 months later and we discuss with them what they have gathered in the information, and then we go ahead and we tell them our professional opinion. The first thing we do is we have the option of the free non-string attached seminar. They come in, all the team is there, we explain to them what we are about and what are the results. This is one step. The other step is patients come in and we do a consult. The first 2 steps are what we call nutritional and psychological clearance. Nutritional clearance meaning that they will see one of our dietitians, and this dietitian will go with them, explain to them what food is, what are proteins, what are sugars, what's the good stuff, what's the bad stuff. The other part is the psychological issue. The psychological clearance gives us this information that this person really knows what he or she is getting into. After when we have that, they come back to see the surgeon again. And that's when the decision is made which type of surgery. The majority of patients, like I said before, they are really extremely smart about this issue. And it's very clear when a patient comes in and we feel like this patient won't be responsible. They have to be involved in that, and it's a team approach and the patient is part of it. We are very clear about it in our program. We send people to different subspecialists. And the reason we do that is because we are convinced that everybody can lose weight, but we also are convinced nobody will keep the weight off unless they go through all this. We have a multidisciplinary team, and there is no weight loss surgery that should happen without having this team, because the most important part is the follow-up and the preparation. The weight management team at MidState includes dietitians, includes social workers and psychologists. Then we have the surgeons. We have the very important, not all the programs have, is a pharmacist. We found this incredibly helpful because they have the medications and absorptions, and they are all issues that pharmacists helps us with that. It's extremely crucial. There is something called the support group. We have it on a monthly basis. The open support group includes the people who had surgery and the people who didn't have surgery yet. So they meet them and they discuss the issues and stuff. That's very important. The closed support group, even myself, I am not invited to. It's only our psychologists, and even the family members are not invited. The patients who go to the support group, I never see them in the emergency room, unless there is some issue. Before we knew that there were multiple factors, we thought that we could just restrict the patient from eating too much or make them not to absorb whatever they ate. But we are finding now that bariatric surgery, the best work it does is manipulating the hormones that are related to obesity. So I think ultimately the obesity will be a hormonal issue. They are not loyal just because of the proximity. They are loyal because they see the results. And they see the human factor you don't see in bigger institutions. That's why many of us are here, and that's why many of the people come to see us.